Apologies in advance if my talk is a little bit too basic for some of you. What I tried to do is, given that we're going to have a talk on lutetium therapy specifically after this, to touch as little as possible on that and to give you as much as possible on the real basic components of how we see the radiotheranostics approach existing as such. And in order to do that, we have to start with a little bit of a refresher on the basics of radiation, right? So radiation is energy that's either produced by atoms that undergo radioactive decay or that is produced by a machine, yeah? As such, energy has the form of waves and within the electromagnetic spectrum and is differentiated in non-ionizing and ionizing radiation by the fact that ionizing radiation expels electrons from the atoms as it goes through matter, right? So ionizing radiation is the basis for all or most of what we know in both the imaging and the therapeutic spectrum with X-rays. In the diagnostic spectrum, we use the ionizing radiation as part of X-rays, as part of CT, as part of general nuclear medicine, bone scans, VQ scans, as part of PET scans. Very importantly, in imaging, what's not ionizing radiation is anything that's to do with MRI and anything that's to do with ultrasound, right? So that's kind of the very basic starting point. When we think about molecular imaging, nuclear medicine, and PET being a big part of this, we have to really kind of take a step back and think of the basics of what is it that we are injecting into patients? What is a radiopharmaceutical? And the easiest and best way to think about this is that that injection contains two different, very important things that are both required to generate an image or to produce the desired treatment. One of them is purely a radioactive isotope, right? The radioactive isotope, by definition, is just going to be a compound that is unstable because it has too much energy, and it's wanting to offload that energy in one way or another, and we'll see which ones of those are used in the diagnostic and in the therapeutic spectrum. But as importantly is the fact that we always need a second component, which is that biologically active molecule. Yeah, so two different parts. Right? So the isotope, the form that it will take, will depend on how it chooses to expel the excess energy that it needs to release. So in the case of PET imaging, PET is positron emission tomography, we have a isotope that has too many protons, so it attempts to expel the protons through positron emission, right? Relevant to this talk are the two most common isotopes that are used, 18F and Gallium-68. Off the bat, I introduce this because it's so big these days. We talk about PSMA PET-CT. It's important to understand that PSMA PET-CT is actually an umbrella of multiple different compounds that are trying to do the same thing, targeting the PSMA receptor, and they're all, by definition, requiring the presence of a radioactive isotope. Without an isotope, we don't have an image, right? So PSMA is purely a receptor. If you inject PSMA into someone without the isotope, the image is blank, right? Some of the existing available FDA-approved agents use F-18. Some of them use Gallium-68. There are subtle differences within them. Given that this is a talk about metastatic prostate cancer, there are clinical implications if your patient undergoes PSMA imaging with one agent at one time point and with a different agent at a different time point. But the basic rationale for their use is the same. No matter which compound you use, it will always have a radioactive isotope, it will always have a biologically active molecule, and it will always decay by emitting that proton, positron emission. Now, that's in the diagnostic space. In the therapeutic space, we have much higher energy compounds that are going to undergo the same principle. They have too much energy, and they need to offload it in one way or another. One way to offload them is through the emission of beta particles. The beta particles will result in one proton, decrease of one neutron, and decrease of one electron. And another way of decaying is through the emission of an alpha particle, right? The alpha particles results in the decrease of two protons and two neutrons. That illustrates the fact that they have different mechanisms of actions, and we will touch upon that shortly. But it also touches upon the fact that there's different energy levels, and everything that we're thinking about in the diagnostic spectrum of theranostics is going to always correspond to the lower energy levels. Anything that we're contemplating or thinking about in the therapeutic component is always going to be related to the high energy compounds that we're talking about here. The biologically active molecule, why is it there? You would think, why don't we just inject the isotope? Well, that's what's traditionally been called the tracer, right? Because it's kind of what the compound or the injection is going to chase. It will determine the anatomic distribution. If you look at a PET done with FDG, the biologic distribution is going to look very different to if you look at a PET that's done targeting PSMA, then if you look at a PET that's done targeting choline, et cetera, et cetera. So very important slide here to contemplate both in terms of understanding what your patient is undergoing, but also thinking about the future, because when you think about it, the combinations are endless. You can combine different isotopes. Each of them will have advantages and disadvantages with different types of tracers, biologically active molecules, targeting different parts of importance in each cancer's biology. So that's the general principle, right? So let's then break down the whole theranostics principle into the two components. And let's start with the gnostics, the diagnostics. How does that work, right? So that functions as any diagnostic PET exam. The same principle, you're going to have a radionuclide combined with a biologically active molecule that's injected into the patient. The localization is going to be driven by the nature of that biologically active molecule, and it's going to localize both to physiologic organs and to tissues of interest. In the case of PSMA, to the site of the primary and the site of the metastasis. Now, how many of you have thought about what actually happens after the injection is done, and how do we go from that to generating an image, right? I've tried to make it as simple as possible here so as not to overwhelm you, but in essence, what happens is once the compound lodges, for example, at the site of a metastasis, the proton moves a couple of millimeters from that side, collides with an electron, and undergoes this process called annihilation. The annihilation results in the emission of 2 photons of a specific amount of energy, 411 keV, that go or move in opposite directions, 180 degrees from each other. The principle of PET scanning is that you have that detector ring around the patient, and it's going to sense whenever a photon reaches one detector and a corresponding photon reaches another detector that's at 180 degrees from the first one. The moment it senses those 2 photons, it records it as a concordant detection, right? And then advanced computational technologies, including something called time of flight, is used to then trace back the difference in time between one photon hitting one side of the detectors and the other side of the detectors to work backwards to know exactly from which part of the anatomy the annihilation process occurred, right? So the photomultipliers in the detector ring are the primary function of generating this image. And one of the practical aspects of understanding this process is that the PET technology has improved dramatically in the last 20 years, and it has continued to improve. The latest improvements in the technology mean that the field of view of each individual acquisition, those of you that have seen PET scans being done, you know that they're usually done by table position, so you can only normally cover about 20 to 30 centimeters at a time. So the patient is in the scanner, you do 20 centimeters, 3 minutes, then you move to the next 30 centimeters, 3 minutes, and you do it sequentially like that. Current scanners, there's existing whole body scanners that have 140 centimeters field of view that allow acquiring an entire PET-CT in 3 minutes. That's already FDA approved, and that will be coming down the pipeline. Most traditional vendors now have PET scanners with field of view that are at least 3 times what we consider convention, so around 60 to 80 centimeters. And you can use that improvement in field of view in many ways, but one of the most efficient ways of using it is by optimizing throughput. right? So there are centers that are doing 40 or 50 PET-CTs per day based on these improvements in the technique. So just some pearls from the Gnostics component, right? So then what about the Thera component? And why are we actually trying to combine them both into the same word if, in theory, something is applied to diagnostics and something else is to theranostics? The glue between the Thera and the Gnostics part is actually the biologically active molecule. If you remember what we said before, in order to do a PET scan, you need to have a radioactive isotope and you need to have a biologically active molecule. Well, people worked out that if you take that same biologically active molecule, but instead of labeling it with a diagnostic isotope like F-18 or Gallium-68, you actually label it with one of the high energy isotopes like lutetium, for example. You can actually then use the same compound to produce either beta particles or alpha particles, depending on the isotope, that will localize to the exact same areas that you saw on the diagnostic PET-CT. So all of a sudden, you're able to visualize where these high energy radionuclides are lodging into the body and emitting their therapeutic, either beta particles or alpha particles, right? No matter how we're approaching theranostics, in which cancer and using which agents, this principle is always the same, having the isotope component and having the biologically active molecule component to it, right? So talking then about the therapeutic part, we said that these are high energy nuclides that stabilize by emitting some of their excess energy in one way or another, right? Some specific agents choose to stabilize by emitting alpha particles. The examples relevant to us in prostate, radium-223 and actinium-225. Some different compounds choose to liberate their energy by emitting beta particles. The examples, lutetium and samarium, right? Which one is better? It's not a matter about better or worse. They're different. You have the differences between the two here. Alpha particles have higher energy than beta. They, however, have less penetration. The beta particles are more penetrating. The alpha particles travel less in tissue because they are heavier. The beta particles travel farther, but the alpha particles induce more tissue damage at the sites that they reach compared to less tissue damage with beta particles. So you can immediately see how there's pros and cons for using one or the other. So the decision to develop a theranostics agent is variable and multifactorial. Part of that discussion is whether it decays through the emission of alpha or beta particles, but that's not the solitary point to consider in that respect. So if we combine these diagnostic, these therapeutic tools, targeting the same molecular targets, usually in the space of prostate cancer, their cancer cell surface receptor overexpression, it overarchingly results in the advantages of having more accurate selection, relatively cancer specific, and opens up the window also for improved response assessment, because if you have detailed information of where the abnormal tracer accumulation was present prior to the theranostics treatment, you can do serial monitoring and observe the changes in each individual sites of disease with very high precision, right? Of course, we're highly interested in this space currently in lutetium PSMA, but be aware that this has been done for more than 50 years as a concept in the space of thyroid cancer with iodine treatment. So it's kind of what we're doing now is nothing new in terms of the ability to combine the diagnostics and the therapy. It's basically just doing it in a fancier way, incorporating the PET component into it and addressing some of the limitations of some of the earlier treatments. Of note, the only other area where this is standard of care and FDA approved is for the use of lutetium tagged with somatostatin analogs for the treatment of neuroendocrine tumors. And that's actually received recent approval for use in meningiomas as well that overexpress somatostatin. All right, so without getting into, again, details about the lutetium PSMA per se, but thinking about the general things to consider when you're approaching the theranostics conundrum, In terms of safety and biodistribution, well, the goal is always the same. The goal is to deliver the radioactive agent, either the beta emitter or the alpha emitter, to the site where the disease is so that it can take its effect locally. The problem is that the agent will not just accumulate at the sites of tumor and metastasis, it's also going to accumulate at sites of physiologic distribution. And that's going to be a major driver of side effects and limitations of how much radiation you can actually give. If you could give more radiation, then there would be more cancer controlling effect, but there would be unbearable side effects. And in the case of PSMA, the physiologic distribution is, as you see on this picture, the vast majority of it is distributed between the parotid glands, so that explains the side effect of xerostomia, liver and spleen, blood pool, and also in the urinary tract and in the bowel, right? So again, this is the case of PSMA. If we were to use another agent, then the biologic distribution is different, and then the side effect profile would vary in response to what the distribution of that other agent is. Another consideration is, okay, we think of the Gnostics part of the Theranostics. We also have to consider that there may be discordancy in the Gnostics part, right? And this is something that the prostate cancer community can vouch for and is well aware of due to its presence in recent trials. Discordances between the uptake of metastasis on PSMA PET-CT and FDG PET-CT. And as is intuitive to think, if you have metastatic disease that does not take up PSMA on PET, it will not take up PSMA on lutetium either. So an explanation, a direct explanation for lack of response of some whole patients or more often individual lesions is a patient that has discordant Gnostics, as I'm calling it here, right? Lesions that are, you have in this example, this particular patient has lesions in the skeleton that are predominantly PSMA avid and less so PSMA avid, but the patient also has FDG avid liver metastases that are not PSMA avid, right? So there's biology driving this differentiation, but the absolute recognition is that this phenomenon exists in these advanced stage of disease patients, right? So the notion here is that we need to be mindful always that the Thera component is going to follow the Gnostics component. So whatever it is that we're injecting for diagnostics, wherever that accumulates is going to be the same place where it accumulates for therapy. And if we are aware of other sites of active disease beyond that, we need to also be aware that those sites won't undergo treatment with the given theranostics agent and will need to be addressed separately through another methodology. So this happens not just in prostate cancer, it happens actually in most cancers that at some late stage of the diseases undergo dedifferentiation and increased aggressiveness. It was initially reported in thyroid cancer, which is actually one of the cancers together with prostate that does not take up a lot of FDG, the classically used PET-CT agent. Most thyroid cancers, even when metastatic, are FDG negative, but it's well known that at some point they undergo dedifferentiation and actually become FDG avid, and that's a sign of resistance to iodine therapy and a sign of imminent progression and death. You see it in the neuroendocrine tumors, and by extrapolation, you've come to see it in the prostate cancer population as well. So another general consideration of the theranostics approach in general, and also specific to the lutetium PSMA, is that it actually works, but it works for some patients and not others, right? So a lot of what the future should bring for us in terms of knowledge of theranostics is further dissecting who is it going to work on, who is it not going to work on, how should we use it, and what's the best strategy for its approach, right? It's not something that is going to be useful for every single patient as a whole, yeah? It's encouraging to see that a lot of these questions that the entire community has are currently being addressed in ongoing trials. You'll see that most of these trials are using the beta emitter, the same lutetium. Know that a lot or some of the future directions beyond these trials are what other combinations of high energy isotopes and molecularly active biologic agents or compounds can be used. And just to finish up, I mentioned this one. I don't know how many of you are familiar with it, just because there's a big hype about it in the imaging community, the use of this molecule called FAPI, fibroblast activation protein inhibitor, which is shown to be present in multiple different cancer lines in vitro and in vivo, and has most recently been labeled for diagnostic purposes with gallium. And as we've talked about, the exact same principle, the gallium is taken up and labeled with lutetium as well for the theranostics part, and it's proven. I think this was a prostate cancer, a pancreatic cancer patient. So this is likely to enter clinical trials in the prostate cancer space as well. So take-home point, basics of theranostics: understand what the current options are clinically and what's in the pipeline. Guiding patient selection, be mindful that the Gnostics drives the Thera part of Theranostics. So you have to know that if there's discrepancies between different diagnostic modalities, those same discrepancies will have impact on the treatment. All that should help maximize effect, outcomes, and set the agenda for future theranostic pipelines. Thank you so much for your attention.